we're gathering information. So there's this discovery phase where we're saying like, tell me about it,
Yeah.
basically.
I like that.
Proprietary, yeah. Uh,
Yeah,
so
your bill is in the
sorry, that's
mail.
copyrighted.
You can't say that.
So yeah, that's the discovery phase.
Well, welcome to Tell Me About It. This is the show where I interview various professionals to get insight into their daily lives on the job. Everybody has a job, and every job is interesting. And today I've got a very special guest, Steve Panosian, who is a nurse practitioner. So, Steve, just start right there. Give me the job board description. What is a nurse practitioner? And then we'll jump in from there.
Yeah, so thanks for having me on. Nurse practitioner, we take care of patients. We are considered a mid-level provider, which is sometimes seen as derogatory, but it doesn't hurt my feelings. But essentially,
paid either way.
yeah. We generally function in primary care, although you can specialize as a NP as well. But we bring patients in, we manage their chronic conditions, things like diabetes, high blood pressure, high cholesterol. And then we also deal with acute concerns. So if you have a cough, you have a sinus infection, break your foot, things like that, we evaluate and then treat, and then also triage out to different specialists.
Okay. So let me ask you, I'll start with the hard question, right? Nurse practitioner, doctor, physician's assistant, med tech. Dice those up for me.
What's the difference?
What's the difference?
Yeah, so a lot of the roles over the years have actually meshed between doctor, nurse practitioner, and PA.
Okay.
Med tech would be kind of a different subset.
Okay.
It's not a provider level role.
Okay.
So doctor and PPA would be your three provider level roles that we would consider. So a doctor, just to look at like education path for that's one of the major differences.
Okay.
A doctor would go through 4 years of undergraduate school, get their bachelor's, then they would apply for medical school. You take the MCAT, you try to get accepted into a medical school, which is another 4 years.
Okay.
So you go to that. And then after med school, you go to a residency program.
Okay.
So that's where you get selected. You kind of pick your top, I think 3 is what you get to pick.
Mm-hmm.
Like I'd like ortho, dermatology, and like OB. It might be your top 3. And then you would get matched to one of those.
Okay.
And then your residency will be usually between 3 and 5 years. And so you're looking at like a 12, 13, I guess 11 to 13, 14 year pathway to become a full doctor, if you will.
Yeah.
Like completely done with schooling, residency, everything.
Yeah.
The NP route is different, or we'll look at the PA route first. So PA would be a 4-year bachelor's degree, and then you would apply for a master's program between 2 and 3 years for PA school, and then you would be a PA. Historically, PAs have had to work under a supervising doctor. That is kind of in flux now. So I think a lot of the shortages of providers has driven that. And so they've actually opened up a lot of PAs to practice more independently in certain fields, especially primary care or urgent care, things like that. But you used to have to work under a supervising physician. So that was one of the major distinctions. And then a nurse practitioner, it would be 4 years of undergrad. A lot of NPs, generally you go the nursing route. So you do a 4-year nursing degree. Most of us will go work as a nurse for a couple years.
Okay.
Or 20 years sometimes, and then decide to go back for a master's, and it's between 2 and 3 years. One of the big differences is a PA, they expect you to be a full-time student in your master's program.
Oh, okay.
As a nurse practitioner, most people will work during that time. So you're working as a nurse, and you're going to school as well.
Okay. Interesting. So, like the stuff that a PA and an NP are learning in school, that's all the same? Is it the same stuff, or is there some like difference in where their education leads?
It's going to be similar.
Okay.
And that leads to some of the differences. There are also some major differences. So a PA program follows more of a medical school model.
Okay.
And so you'll have blocks where you're doing like rotations in primary care, rotations in ENT, rotations in surgery, rotations in this. So more of a medical school model. And they also allow you to sample a lot of the different specialties, which is kind of unique to the PA program. So you'll see a little bit of a bunch of different specialties, by the time you get out. And then once you graduate, you can really work in almost any field as a PA.
Okay.
And that's one of the other differences. So you have surgical PAs who are actually doing surgeries with doctors a lot of times, or minor surgeries that maybe the doctor is pushing to the PA. They'll work in the ERs a lot, very good in the ER because a lot of technical stuff with suturing and small procedures is done in the ER. So PAs are usually really, really good at those. The NP model, the first year, you do a lot of anatomy and physiology. There's some nursing structure and leadership because it's a master's in nursing. So they also look at you as like a nursing leader. So some people get that degree, but then they end up going into like nursing management or things like that. But we focus more on primary care. So most NPs are going to work in a primary care setting, urgent care setting. They have...
When you say primary care, that means just like my doctor's office. That's primary care. Okay.
Yeah, correct. So it's a lot of chronic care management and acute care management. Less nurse practitioners go into like ortho or derm. You can definitely do that. Cardiology, they'll hire NPs quite a bit.
Do you see nurse practitioners in the hospital? Are they the ones that are just like behind the desk managing the nurses?
So that would not be an NP doing that. That would be like a charge nurse or somebody who probably specialized more in nursing management or hospital management than the NP route. So there are hospital-based NPs. That's usually a difference in your master's major, if you will, or master's focus. So we would all have a MSN, Master's in the Science of Nursing, but there would be a family nurse practitioner focus. There'd be a pediatric nurse practitioner focus. There's acute care nurse practitioner focus, which would be hospital-based. And then there's a geriatric nurse practitioner focus, so you're really just seeing older people. So I am a family nurse practitioner, so I can see birth to death. If you are a pediatric, you kind of cap out at, I think they let you go to 21, but then you're actually practicing outside your license if you see people older than that. Geriatrics, you start at 18 and go up, so you're like an adult. And if you see under that, you're outside of your scope. And so as an FNP, I have a very broad scope of practice. I would be a generalist, so I have a lot of knowledge in different areas, but not a ton of knowledge in a lot of areas. So I specialize a little bit more in diabetes. So that's like my go-to. So I'm not an endocrinologist, but I would specialize in the care of diabetes. But I also have a broad scope in a lot of other areas.
Interesting. Talk through, so you're on the education track. Talk to me a little bit about like licensure, certifications, ongoing education, how that works in your field.
Yeah. So I started with my 4-year bachelor's in nursing from Cedarville. So I graduated with that. I went to work in the ER as a nurse practitioner, as a nurse for 2 years or so. And then I went back for a MSN.
Was your plan to always go nurse practitioner, or did you get in the ER and were like, holy cow, I need to...
No, that was my plan to be an NP. So I kind of already had a thought in my mind about probably midway through or even the beginning of nursing school that, hey, I'm going to work for about 2 years and then go back. At the time when I was coming through my bachelor's program, they actually most schools required 1 to 2 years of nursing experience. So they didn't want people going straight through. You learn a lot on the job as a nurse that then helps you as an NP. And so I already had that in mind. So I worked for pretty much right on 2 years and then started back. And then once you graduate with your MSN, you can't really do anything with it other than go into like nursing management because they want a master's. But to actually be an FNP, then you test. So there are 2 boards that you can test with. So I chose the AANP. So I took that test. They then issue a certificate saying, hey, you're an NP now. Then you have to go to the state and get your license. So the licensure, you still use your nursing license. So you have to have an active nursing license. And then they call it an endorsement on your nursing license for an advanced practice registered nurse. So we're called FNPs, but the technical term is advanced practice registered nurse. So I now have a RN license and a APRN license that endorses that one.
Gotcha. And you said there's 2 boards to test with. What are the differences between the 2?
Yeah, not a whole lot practically. You're going to be
Are
able
they just
to
like
work.
privately owned competing nursing boards?
Essentially,
Like, how's that?
yeah, and they put out different tests to then be certified. So as you're getting ready to graduate, everyone's like, oh, what test are you going to take? Which one's easier? And what's the pass rates on the different ones? And the school I went to generally just encourage the AANP.
Okay.
They have a really good review program,
Mhm.
someone that runs it. And so the review programs for the two different ones will focus on different areas, different question types and such. So
Mhm.
you really have to pick a track and stick with it. And then you
Mhm.
buy the review course and then you go through it and then you pay for your
Okay.
test. And
Are you
then
choosing
you
that
should be
early
good.
on in your education, or you can
No,
wait?
that's
Okay.
going to be right at the end.
Oh, okay.
Yep. So you can't even sign up to take those until you get your graduation
Mm.
paperwork. So I graduated beginning to middle of December
Mhm.
in 2019, and then I tested on the 30th or 31st, so I was able to test pretty quick.
Okay.
But you're starting that review process the last semester. So pretty much
Okay.
all the fall I was studying, and I had picked, I'm going to do the AANP.
Yeah.
And then you sign up for it and then pick your date and all that.
Gotcha. You graduated your master's program in 19. So you
Correct.
were 17, graduate, call bachelor's, nursing
So
ER for
I
2 years.
I graduated in 15 with my
Okay.
bachelor's.
Okay.
Worked for 2 years. Started in 17,
Gotcha.
and that's about 2.5 year program.
Gotcha. Did you work during that master's then?
I did. Yep.
Okay.
Yep. So I was still in the ER for the first section, and then we moved to Arizona, and I started working in a correctional facility,
Awesome.
prison.
Yeah.
And so it was interesting. It wasn't my first choice, but it was helpful.
Mhm.
The prison, they set you up to work under protocols, they
Okay.
call it. So as a nurse, you're seeing patients independently. You're making clinical decisions,
Mhm.
but they're guided by a protocol. And
Okay.
so it really helped get me in that mindset of like, this is my patient. I need to decide what I'm going to do with it,
Yeah.
and then back it up with charting and back it up with the protocol. And so when I graduated, I kept working at the prison for about a year.
Yeah.
And essentially, I was doing the same thing, just without the protocol, and I could prescribe anything instead of just the protocol stuff.
Yeah.
So, yeah, it really helped prepare me better.
So I imagine working at an ER and working at a prison, I feel like those are a couple of pretty extreme environments for for medical care. Is that something that seems to be the norm for people who want to go for that further, like NP or PA or whatever? Does it benefit you to try and get in that more extreme environment, or is that just something that your personal taste was like, I want to be in the thick of it?
Yeah, sure. Yeah, I knew I wanted to be in the ER coming out of college,
Okay.
and part of that was my wife was an EMT.
Mm-hmm.
She would really push for that. She loved that, so I'm like, hey, I'm gonna try it too, and I really
Yeah.
liked it. Um, but you do see a lot of NPs come out of ICU
Mm-hmm.
or the ER.
Okay.
The and those are completely different things, but they're
Sure.
both kind of at those extremes. So
Yeah.
the ER, we never know what's going to come through the doors.
Yeah.
So that prepares you as an NP, because a lot of times someone shows up and you may say, hey, I'm going to see my doctor, and you call in and you have like 5 things that you want to ask.
Yeah.
But they're going to be like, well, what are you there for? And you're like, a cough.
Yeah.
So I just have cough.
Yeah.
And then
Okay.
you walk in the door, and actually it's something completely different maybe.
Yeah.
Or you're like, well, I've had a cough for 5 years, but I really want to ask about this
Yeah.
and a cough.
Yeah.
And so I think the ER prepares you well in that sense, because people
Okay.
do the same thing in the ER.
Yeah.
What are you here for? Well, it's these 5 things, but really this is the one that prompted me to come.
Uh-huh.
And then you're doing this exploration mission to figure out what actually is the problem.
Yeah.
So it's good in that sense. It's pretty fast paced in the ER, so that also prepares you well. The medical system wants you to see
Mm-hmm.
a lot of people, and even if you have time, you need to kind of work through things quickly, come up with a game plan within that appointment time, and then enact it. The people that come from the ICU think very differently. So ER, it's a little more run and gun.
Yeah.
And the ICU, it's very analytical.
Okay.
It's process oriented.
Mm-hmm.
And those people make really good NPs as well,
Mm-hmm.
because they think a little more start to finish.
Mm-hmm.
A little bit different,
Mm-hmm.
but very analytical. And those people are very smart as well. And so
Yeah.
they get to see different things than the ER.
Mhm.
Usually after we package them up and then kick them up to the ICU, then they have to figure out what's actually going on. We just kind of like, hey, we stabilized them.
They're
your
not going to
problem
die
now.
now. You take care of it.
Yeah, literally. There have been patients that I look back and I'm like, man, we really just like package that guy up. He's breathing. He has a heartbeat, and push him up to
Get
ICU
him on
and
outta
then
here.
run out of there. And then they take over. So very different experiences,
Uh-huh.
but they make very good NPs on both sides.
Talk to me a little bit more about the ER, because I think that's fascinating.
Yeah,
Let me start with what do you see as the percentage of like Johnny stubbed his big toe, so we need to go to the ER, versus like my friend just got shot. We got to go to the ER. What's the kind of the statistics there?
Yeah.
What do you see more at an ER?
Yeah, and that would probably depend on where your hospital is located. That'll
Okay.
be a big part of it. So, I worked in an area where we had probably 10 hospitals within an hour radius if you were to go
Oh,
to
wow.
the center of them and go out. So it wasn't a big city. It was like 100,000 people in the city proper, and
Mhm.
then just a lot of farmland and smaller communities outlying. But we had a lot of health infrastructure, and we were not a trauma center. So
Okay.
that's going to separate things pretty quickly there.
Yeah.
Um,
Trauma center being like horrific accident, violence,
yeah.
whatever,
So as an
major
ER,
events.
you get ratings, trauma 3, 2, and 1. 1
Okay.
being like the most critical patients. And that's all based on resources that you have at the hospital.
Okay.
Doesn't mean that you're not going to get them.
Mm-hmm.
But a level 1 trauma center, you have to have like a trauma surgeon on call 24/7.
Okay.
You have to have neurosurgery on call, at least, one person that could get there type of thing. And there's a lot of other qualifications for a level 1 trauma center. But we were not a trauma center. And so we would get all of your regular stuff like, hey, I got a stomach ache. I have appendicitis. We get a ton of drug overdoses, and that was based on where we were located. So
Okay.
we were in kind of a little more lower socioeconomic class area, right off of I-70 and 75. So we were like within a mile of the 75-70 interchange.
Okay.
And so at the time that I was in the ER, there was a ton of drug trafficking that would come through Indianapolis, and then it would go east on 70, right past our hospital, past Dayton, and then to Columbus, which was another like major hub for heroin, fentanyl, carfentanil. So we would get a lot of drug overdoses where people were just like, hey, this person that I'm with is not breathing. I got to get him to a hospital. So literally one time I was working at the front desk. It was like 11 o'clock at night, and the doors open up, and this guy like pushes a wheelchair and just lets it go and runs out the door. And this lady was like slumped over in the wheelchair. So, you're rushing back, and, we brought her back with the Narcan and stuff.
Yeah.
But that's more of what we got. Percentage wise, I would probably say it's like 20% stuff that you really shouldn't be going to the ER for, that you could probably do it in urgent care or your primary care office. 20% on the other side is like you have to be at a hospital or you could die type of thing. And then the 60% in the middle is all the, hey, I don't really know what's going on, but I'm concerned about it enough that I'm going to go to the ER.
Gotcha.
And I want it dealt with tonight.
Yeah.
So that would probably be my breakdown. And some people just use the ER as their primary care office.
Yep.
So that's what we see a good bit of. When I was working in Ohio, their like low income health insurance system allowed you to be seen in ER for like zero cost. And so why go make an appointment at your primary care office when you can just walk into the ER? They're going to do the test right there. You'll get your CT scan right away.
Yeah.
You're not making like a lab appointment, a CT appointment, a doctor appointment. You just go and get it all done. So why not? So we would see a good bit of that. You also get a lot of nursing home patients where there's a lot of times an NP that will staff those, but they're only coming by once or twice a week and doing a round on people. So if something happens in the middle of the night, they're not going to drop everything and come. So it may not be something super critical, but the person needs it addressed fairly quickly. And so they'll bring them in. And then we end up sending them back that night.
Yeah.
Yeah.
Cool. That's like a lot of experience in a really short amount of time, I imagine. And that kind of makes sense then why your NPs would go those sorts of routes where it's like, I just want to kind of load myself with as much experience as I can so then I can, move to this next step.
And the NP experience in the ER is very different than the nurse.
Okay.
And so...
Because you were on both sids of that, right?
No, so I never worked as an NP in the ER, but I knew I didn't want to do that based on my nursing experience. And so the ER is all about managing viability. So one of the really good things I learned in the ER that translates to what I do even now.
When you say managing viability, give me a brief.
Liability.
Oh, liability.
Yes.
I'm like, viability, I think.
So
that I can kind of understand.
Right. So this is what I still use now from the ER on a daily basis. Someone comes in primarily with acute concerns like, hey, my back sort of hurts. We don't just want to say, hey, well, it's probably a strained muscle, so go ahead and stretch and take a muscle relaxer and don't lift anything for the next couple of days, and then send them out. That is the most likely thing. And so that's generally what we're going to go with. But you always want to think about the most likely thing and then the worst thing.
Okay.
Or most common thing and the worst thing. So,
Okay.
yes, it could just be a strained muscle, and that's probably what it is. But you also want to go down that pathway, making sure it's not an abdominal aortic aneurysm that's rupturing, and they could die like in 10 minutes.
Okay.
So that's what the ER teaches you, is to manage that. And so as a nurse practitioner, especially in the ER, we would see a lot of our doctors had enough experience, and they had done their residency, and they had been through enough that they could look for things and kind of rule out things without doing a $50,000 workup.
Yeah. Okay.
But on the NP side, there's a little more of that pressure where maybe the patient doesn't trust you quite as much. The doctors are looking over your shoulders a little bit. You're also like, hey, I don't want to screw this up.
Yeah.
And I don't have quite as much experience, or I didn't do a residency in the ER specifically. So you end up ordering a lot more. The nurses hate that.
Yeah.
When it's like a abdominal pain patient, and we're like, well, they ate 10-day-old sushi last night, and now they're throwing up. So we probably just need to hydrate them and give them some Zofran and treat them.
Yeah.
And then the doctor comes in and agrees and like, yep, you shouldn't have eaten that sushi, but we're going to hydrate you up. You're going to get home. You're going to be okay.
Yeah.
And then the NP walks in and is like, hey, we're doing a CT. We're doing full lab work. We're doing a stool sample. We're going to get a urine. And it's like this.
And the nurse is like, great.
Yeah, great. You just made my job horrible.
Yeah.
And in the ER, you also separate out. Most ERs will have like a fast track area, they'll call it, or something like that, which is supposed to be low acuity. We use a ESI rating 1, 2, 3, 4, 5, with 1 being like you are dying, you are in cardiac arrest.
Yeah.
And 5 being you need a refill on your lisinopril.
Okay.
And so the fast track area is supposed to be those 4s and 5s where no one's getting an IV. Maybe you get blood work, but generally not, because that would bump you up to the 3.
Yeah.
And those people are supposed to turn over really quick. And so as a nurse, you might be managing 6 patients in that setting, because you can get them going quick and they're not taking a whole lot of time. It's kind of, hey, what are you here for? I'm going to chart on you. And then the NP is going to come in and manage you. And then I'll kick you out when you're ready.
Yeah.
And so those NPs that work in that area, if they're over ordering, then all of a sudden you might have 6 ESI 3s when you're only supposed to have 3 to 4 of those in the back. And so that kind of screws up your whole day.
Yeah.
And then you're doing way more work than you're supposed to do. So I knew that I did not want to be in that situation.
Yeah.
And that I
yeah, because that's pressure from both sides. You got the management above you being like, why are you ordering all this stuff? And then you have the nurses being like, why are you ordering all this stuff?
Yeah. In the health system, we'll probably talk about this a little later, but in the ER, everything is stats. So they're like, how long is that patient from when they check in to when they're in the room? How about from when they're in the room to seeing the doctor? How about from when they're seeing the doctor to getting out of there? So all those things are building up on you. So yeah, you're getting the pressure from management, from the nurses, from the patients, even from fellow providers, where they're like, why are you doing this? Or like, you're a bad provider because you don't trust your gut, or things like that. You know, you're getting all this different pressure. So I knew I did not want to be a ER NP. Yeah.
Okay, cool. Okay, so then let's jump into your more day-to-day. So your family nurse practitioner, talk to me about your organizational chart. Who do you report to? Who reports to you? Where do you fall within that?
Yeah. And it's a little different than a lot of places. So I just left a clinic that's a more typical setup. So in that clinic, I was provider. I had somebody working under/with me who was my medical assistant. So they would...
Real quick, how do you simplify provider? Like you say that I'm a provider versus I'm not a provider.
Yeah, so we would say provider would be like that doctor NPPA.
Okay.
So that's like provider.
Okay.
That we would lump all those into, because a lot of clinics will have all 3.
Oh,
and so there's not necessarily, just because one person's a doctor now with the new setup with PAs and NPs, we would all be considered on the same level.
Yeah.
We may defer to the doctor if we have questions or things like that, but that's provider.
Okay.
So that's the level that I would be at. My medical assistant would work under me, and that's someone that you're paired up with. They do a lot of the ordering. They'll check vitals. They'll give injections. They'll give breathing treatments, things like that.
That's that first person we see when we go to the doctor that calls us back, gets our weight, blood pressure, all that good stuff.
Exactly.
That's the assistant. Okay.
And you work closely with that person all day.
Okay.
So you end up, getting to know what each other wants. So a lot of times she would know what I was going to order before I would even order it, because I worked with her for about 3 years, the one that I was just working with. So that would be kind of under. We also have other medical assistants that float around in the office. So they might be, if we're busy, it'd be, hey, we need a Kenalog injection in room 4. They send it out in the chat, and then that person goes and does it for us.
Oh, cool. Okay.
So that would be kind of the people under, and then front desk is in that group. And then above me, this is where it's a little different. So we have an office manager.
Okay.
So my office manager was a medical assistant.
Okay.
She didn't have other certifications above that,
Mhm.
but she would be the one that runs a lot of what we do on a day-to-day
Okay.
basis. So
Mhm.
she is my first boss, if you will. But
Yeah.
then there's this kind of weird dynamic because she's not really over me. I really call the shots, but she calls the shots for the clinic.
Yeah. Okay.
And then above me would be our chief medical officer. So he is a doctor who has switched over to administration. And
Okay.
so he calls a lot of like the bigger medical picture shots.
Okay.
If we have issues, he acts as kind of like our provider HR, if you will.
Okay.
So if we have issues that are more provider level stuff, or I want this equipment in the office, I'm having this issue with a patient, we would go to him, and then he directs from there.
Okay. Does he see patients as well?
No.
Oh, okay.
No. And
Gotcha.
so he's all admin. And it's a different role because I can kind of do what I want in patient care. And a lot of organizations, they have some oversight there where there's follow-up or there's evaluation of like how are your outcomes and things like that. The organization I just left really didn't have any of that. We used to when we were a smaller clinic, so there would be check-ins, or if there was an issue that I kept running into, he might bring it up and say, hey, when you're taking care of a patient, you should maybe do it this way instead of this. The organization I just left did not really have any of that.
Okay.
And then the organization I'm with now, it's a much smaller operation. So it's me and one other provider and one medical assistant that we share.
Okay.
So that's been a shift as well where me and him, he is my boss because he hired me, but we're also both NPs. And so we work very closely together. We see our patients independently. We do some knowledge sharing is a big thing where, hey, I've got this problem. What do you think? And we may defer to that person's experience.
Okay.
He defers to me a lot in diabetes because he doesn't have a lot of experience with that or doesn't specialize in it. And then he's really good with like musculoskeletal issues. He does a lot of joint injections, which I do not do. So I'll push people to him. So there's a lot of knowledge sharing, but it's less of this hierarchy.
Yeah. So NPs can have their own practice, like total practice. Is that a state thing or is that?
Yes, that is by state.
Okay.
So I think there's 35 states right now
where
an NP can hang their own shingle, and that's what we do right now.
Yeah. Okay. What? I don't know how to ask this tactfully, but why would somebody not want to just go the NP route, start making money quicker? What would prompt somebody to be like, I really want to be a medical doctor at a primary care office?
Sure.
What's the motivation there?
Yeah, the schooling is very different.
Right.
And this is a hot point of contention.
Okay.
My dad's an MD, and so if you ask him, he would give you a very different answer maybe.
I'll have him on the show.
Yeah, you should. Yeah, you should. As I was thinking through it in high school, my thought is I do not want to be tied for 11 years to this education process.
Yeah.
If I had done that, I would just be getting done with residency now, or within the last year or two. Whereas
and you've
now,
been working for 7 years or whatever it is.
Yeah. So I've been a nurse for 10 years.
Okay, yeah.
I've been working as an NP for 5 years now already.
Yeah.
And that was one of my thoughts is if I get going quickly, by the time I'm 40, I might have 15 years of NP experience.
Yeah.
And I'll be close. I'll be at like 14 years by that point. But I think the education is different. So it really does set you up to be a expert in primary care, let's say. And I know some very good primary care MDs, and they are very bright, and they will see things differently than I do. But that's a big debate right now in the medical community. Is a lot of people are seeing it like I did. I don't want to be tied to this for that long. So now there's this big shortage in primary care doctors.
Oh, interesting.
So most people end up seeing a primary care NP.
Yeah.
And you might have one MD at your practice, but you probably will never see them, or you may never see them.
Because I think the common perception is like is almost like a hierarchy. Like you have a doctor that must be hired by the office, and then they've got their NPs, their PAs, or whatever under them. But ultimately, it all comes back to the doctor.
Sure.
I think that's probably a general perception, but kind of what we're learning here is that's not really the case. It's like providers.
Yes. And even if there is that MD at your practice, if you're seeing a nurse practitioner, that MD has probably never heard of you, never seen your chart,
Crazy.
never looked through anything
Yeah.
about you.
Yeah.
So that's where it gets a little different. Some of the old school practices where there is a doctor who started the practice 20 years ago and they're practicing and they've hired different NPs. Some of them run it very differently. So a lot of specialists as well. You'll go and you'll see MD on day one, and then all your follow-ups are going to be with the NP or a PA.
Right.
Until maybe your 1 year follow-up. Then it'll be, hey, let's recap what's happened over the last year. I read through your notes. My NP's been seeing you, and this is where we're at.
Yeah.
So specialist office work different because those guys are specifically trained for like gastroenterology.
Yeah.
And so if you're an NP, you're coming in and you probably have zero gastroenterology experience other than the primary care umbrella that you learned under. And so you're doing a lot of on-the-job training. You're trying to soak up as much as you can from them, doing a lot of maybe go to a conference or things like that. Whereas in the primary care world, we're trained specifically in primary care. So there's a lot more freedom for us to practice independently there.
Okay.
Yeah.
Yeah. Interesting. So let's talk through major and minor responsibilities during a week, and then we'll get into, I want to kind of shift this around from what I told you we were going to do.
Yeah.
I do want to talk about collaboration, but give me first kind of your primary function and role, and then when you're not immediately seeing a patient, what are you doing?
Yeah.
When you're not in that room, and then you can talk a little bit about your medical assistant, because I think that's probably where the main bit of collaboration comes in.
Yeah.
So, let's go there. Let's go. What are you hired to do? What is the thing that you get paid to do? And then when you've got free time, what are you supposed to be doing?
Yeah. Yeah. So I get paid to see patients and manage their care. And so I'm expected, in my current setup, I have 10 patient slots in a 5-hour window, which is very generous on time. The practice I now work at is really focused on, we're not here to just crank patients through.
That's generous? 10 patients
30,
in 5 hours is
30
generous.
minutes is very generous.
Oh my gosh, okay.
Which seems kind of wild when you're managing someone's health.
Right.
And we're seeing, we'll talk a little bit more about that. But anyway, that's my 10 slots. So I'm expected to try to fill that as much as possible. At my previous clinic, I was salary. And so I could see 5 patients in that slot, or I could see 10, and I would get the same pay, although there were bonus opportunities if I did really well.
Sure.
This current one, I'm paid on a contract, so I'm really incentivized to see more patients because I get a certain percentage of the revenue from those patients. But my job is to see them to address acute issues that come up. So, if you are sick or something, people want to be seen for that. But I primarily focus on chronic care management. A lot of my patients are diabetic, probably 70+%. Just because I've leaned into that heavily and I've gotten to know it really well. People see me as a specialist in that. And so I've really leaned into that. So I manage their care, trying to get their long-term control well controlled. Refill medications is a big part of my responsibility, making sure that they're actually going through, filling out paperwork for patients' insurance is a big part of it. So people will come in and be like, hey, my insurance had a problem with this. Can you put this in the chart so that it gets approved next time?
Yeah.
So that's part of it, is managing that patient and insurance role interaction, I guess. So that would be my primary responsibility that I'm paid to do, and to bill that as appropriately. That's ultimately what I get paid to do, is to see you and communicate through your chart what I did for you, and then send that to your insurance so I get paid for it, or our practice gets paid for it.
Sure. Okay.
So that's how healthcare has become a little more of a business, is like the more people you see, the more procedures you do, the more codes you put in there that are billed and then backed up with your charting, the more you make. And so it's become this big business. When I'm not seeing you, there's quite a bit of admin work that we do. Prepping charts is a big thing. So right now on Mondays, I'm there from 12 till 5, but I try to get there at about 11, and then I do 45 to 50 minutes of chart prep where I'm looking at your past notes. Hey, what did we do for this patient in the past? What new meds have we started you on? What were your labs last time? I'm pulling those into your chart so that when you come in, I already have an idea of what's going on. And then we can talk through it, formulate a game plan for the next 3 to 4 months, because I'm seeing most of those diabetics every 3 to 4 months.
Okay.
We also get like progress notes back from the specialists. So you come in and you have to go to the GI doctor. Then I receive those notes back. So we get those faxed to us, and then I have to review those, and they go in your chart. So I'll come in and I have a number of messages that I need to work through. And some
Mm.
of it's just, hey, you saw GI. They said we're going to do this next. So I just check it off and,
Okay.
hey, we've addressed that.
Yeah.
Some of it is labs coming back. So you come in for an appointment. I give you a lab slip. I typically try to have people do their labs 2 weeks before they come in, and then we review them at the appointment. But if you're like a new patient or young people only come in once a year, maybe. And so it's like, hey, I've seen you, go to these labs, and then we'll call you and let you know what's up. So then I get those back. I have to review them and then communicate that to my medical assistant to then call you and tell you what's up.
Okay.
We get a lot of refill requests from pharmacies. So some of the admin time is checking those, making sure it's still appropriate for you to be on that medication, approving it or denying it. And then some of it's seeing, hey, have you been here in the last 6 months, so that I can say that I'm adequately taking care of you and continuing to monitor things. I'm not just like sending you meds for years on end without checking in.
Without actually seeing them.
Yeah.
Okay.
So that's kind of the face-to-face and the off time. Yeah.
Okay, cool. So talk to me about the chart.
Yeah.
Everybody knows the word chart. The chart is everything.
Yep.
What does that look like? What are you actually doing on the chart?
Yeah, and that's probably the most stressful thing about changing jobs is the charting system. So if you go from one clinic to another and they have the same charting system, it's like a burden off your shoulders.
Okay.
That did not happen when I came to this new practice.
So there's not an industry standard
correct
charting system.
That is a competing business.
Interesting.
Because you have to pay to use the charting system.
Like a license that you pay for. Okay.
Exactly. Yep. The one we use now is fairly simple, but essentially what we're doing is we have a list of all your documents. So those will be separated out. So that's a major tab that we're looking at is your past labs, your consult notes, stuff from your insurance that they've sent you or sent us to communicate with you or to send back to them. Then we have your past encounters. So every note that we've ever created on you is in there so that we can look back and reference them.
Okay.
We have then a chart note for that day or encounter note, and that's really what we're interacting with the most.
Yeah. Okay.
So that's what insurance is going to look at to determine if what we said we billed for is actually done and appropriately covered.
Mm-hmm.
So mine has 3 main sections right now. One's called your history section. So it's got a social history, a family medical history, your personal medical history, your medications. So I have to go in and say, I looked at that.
Yeah.
And the insurance looks and make sure that we said we looked at that.
Mm-hmm.
And then the core of the note is called a SOAP note, SOAP.
Okay.
So it's subjective, objective, assessment, and plan. So subjective is, hey, Josiah, what'd you come in for today? And I'm typing out, whatever you tell me.
Yeah.
It also has something inside that subjective called a review of systems. So we're supposed to at least acknowledge that we've covered. Like if you tell me you have a cough, I'm also supposed to be like, okay, but your stomach's feeling good. You're not bleeding anywhere.
Oh, okay.
Your
throw some other stuff out there.
Yeah, we're just trying to make sure. And most of that's done conversationally. We don't sit there and like go through every system usually and ask that. The objective is what I'm actually assessing. So you say I have a cough, so then we're going to listen to your lungs. We're going to check your throat.
Okay.
We're going to listen to your heart, and then we're documenting that. A lot of that's done on templates, and so it's in there, and then we are pulling things out or adjusting things based on the non-normals. The assessment is like what diagnosis we're giving you. So it may be cough or pneumonia or high blood pressure, diabetes. And then the plan is you're taking that assessment and saying, based on those diagnoses, here's what we're going to do about it. Yeah. And then
is that where you put in like, I'm prescribing Josiah X?
Exactly.
Okay.
Exactly. Yep. And because I'm seeing most of my patients on a regular basis, I usually say, hey, we're prescribing this and we're going to look for this at the next appointment, or we may consider this. So then when you come in next time, it's not like starting over again. Hey, I see we sent in this, but what were we going to do about it? It's like I already put it there.
It's already there, yeah.
If this didn't work, this is the next thing that I'll do. So that's one of those growth things that over time you see, I should really put that in the chart so I don't look dumb next time when you come in. You can see that we're working towards a certain goal.
Yeah.
And then the final part that the insurance really cares about is the fee sheet. And this is
this
is it. This is the moneymaker. Yeah. So what do we have to pay this doctor? What did they actually do?
Yeah.
So your visit is going to get coded on a 1 through 5 scale, kind of like that ESI thing we were talking about.
Mhm.
It's different, but it's similar to that. So the code that we generally use is called a 99214, which means we addressed at least one acute and one chronic, or at least one chronic and maybe a second chronic, or we sent some medications in, we ordered labs. So there's certain qualifications to get to that, but that's considered not like the most detailed visit, but this is one step down.
Okay.
And so the insurance looks for you to spend about 30 minutes with that patient between chart review and actual time with the patient, charting, things like that. That's kind of what they're paying you for. So we have to justify that. So we put that code in. Then we have to put all the codes in that the things that we saw you for in that assessment section. And so we're saying I saw him for diabetes and high blood pressure and obesity.
Yeah.
And then we're coding that. So that has justified to the insurance why I asked for a 99214 reimbursement.
Yeah. Okay.
And then if we do other things, let's say we talked about like drinking, that's a alcohol evaluation or a assessment screening. So then we can bill a screening code for alcohol. We do that.
You could just say, Josiah, did you have a beer this week? Yeah, cool. Your insurance is gonna pay me $50 because I asked that question
once a year. And so that's where it comes in.
Okay.
Yeah, they don't want us doing that every time because that would be kind of scamming them. But especially for your physical. So when you come in for a physical, being your age, like we would do a physical code, which is a little different than those 99214s, but you get a physical code based on your age. And so the older you are, the more your insurance pays for a physical.
Sure.
Because it's supposed to be more complex.
Yeah.
But then we can build that, and then we can build a depression screening. We can build an alcohol screening. If you're over 40, we can build a cardiovascular screening. BMI's over 30, we can build a obesity screening.
Okay.
So there's all these things that we can bill, and that's what the insurance is looking at. Is what did they say they do? Does their charting back it up? And then what do we have to pay for it?
Yeah.
And what kind
of safeguards do you put in place personally to be like, I really care about this person's health versus like, this is my livelihood. I need to make sure I can bill as much. And do you see both sides of that in the industry?
Yes, 100%. And that's really the hot topic or the hot debate right now, or maybe the thing that providers deal with. I've worked on both ends of that, even for the same person. So when I started, when I stopped working at the correctional facility, came to private practice, I worked for a independent clinic that was pretty successful. We had like 8 providers there, so we were seeing a lot of people. But the big focus was know your patient, take really good care of them. We're going to cap you at maybe like 20 people per day in a 10-hour day.
Yeah.
And we shoot for mostly 30-minute appointments, or maybe 50-50 on 30 and 15. 15 is more for acute stuff.
That's interesting.
But we really did not bill a lot of those extra codes. It was kind of, hey, talk to them about it, get to know them, but it's not making us a ton of money. We're not trying to get the patient a big bill.
Yeah.
When we sold, that company sold to a bigger healthcare company, which is most of healthcare now, that shifted pretty quick.
Okay.
And it was, what's the maximum amount of patients we can see in your 10-hour day?
Yeah.
So we started getting what we call a grid every day. So it would have your name, and then based on your age and some of your diagnoses, it would tell us what things we could bill for that day.
Oh, wow. Okay.
So, hey, they're due for their physical. Hey, they're due for their alcohol screening. Hey, they're due for their depression screening. And there's also these 3 tests that we can do because he's a 41-year-old male.
Okay.
And once a year, we can bill those.
Yeah.
And so the push became whether they need it or not, their insurance will pay for it, and it's good for their health. That's how it was presented. But I think if you're a perceptive person, you would probably realize, hey, this person probably doesn't need that screening. We can say, hey, it's a screening, so just do it, and then we'll see what comes out, and if it's nothing, then that's great. Initially, it was presented as, hey, if there's a bill for the patient, the company will just wipe it.
Okay.
But the problem was they didn't tell the patients that up front. It seemed like it was more of a, hey, if the patient calls about it, then we'll wipe it. But most patients, when they get a bill, they just pay it because they expect.
Oh man, I went to the doctor, so I got to pay for it. Yeah.
So I definitely fought that. I was able to get to a point because I had a lot of loyal patients and people that came back every 3 months. So I was busy enough where I would kind of balance that and do ones that I thought were appropriate, but I was not pushing the billing like that. But if you practice that way, you know you're not going to get rich doing it. Essentially, you're not going to get all those bonuses and stuff. So the new practice that I work at, they're all 30-minute appointments.
Mm-hmm.
We don't do that extra testing. And I just had a conversation with my boss yesterday that like we're not gonna get crazy rich doing this. We're not gonna make as much per patient.
Mm-hmm.
But we're going to try to take really good care of these patients,
Yeah.
and that creates a loyal patient base. So, yes, you may not bill as much per patient, but you know that those people are going to keep coming back. So,
Yeah, your market's not going to go anywhere.
exactly,
Yeah.
yeah. So there's two different ways to build a practice. One is just we want as many people as possible to come in, and that's where a lot of those new primary care companies
Mhm.
focus,
Mhm.
and they're like, we're going to make it as convenient as possible for you to come in whenever you need it.
Yeah.
And we're going to do you up and bill as much as we can, but that patient may never come back. They might jump
Right.
to the other one.
Yeah, and you see that because I mean, like, doctor's office marketing is all focused on like, oh, we care about you.
Yes.
And if that was a given, then that wouldn't be in the marketing.
Right. Yes, exactly. Yeah. And you can kind of see behind the curtain
Yeah.
as you talk to people who've worked at those ones where you
Yeah.
see the commercial. It's like, man, this looks like a wonderful place where they love me. They know my name. They're
Right.
And then you talk to people who've worked there and they're like, oh, heck no. They just, they see a dollar sign on your forehead when you
Right.
walk in the door
Right.
and they're going to get all of it.
Yeah.
And a lot of it's coming from your insurance.
Sure.
So the pushback from those companies would be, well, no, we're helping people use their insurance. That's why you have insurance. So you can get all your screening tests, you can get your appointments whenever you want. But the next year, when your same insurance plan that doesn't give you anything better, maybe even covers a little less, but the price goes up,
Mm-hmm.
why is that? Well, if we're billing more for insurance and insurance is paying out more over the course of a year,
their rates
for
are going to go
thousands
up.
and thousands of people, they're going to have to charge more to still make their money because they sponsor golf tournaments and they're sponsoring all this stuff. So there's a lot of money in health insurance.
Sure.
So I don't think that's always maybe presented, but both sides are making their money. Insurance companies making their money. The doctor's office is making their money. So the only people that are struggling more are the patients. So the patient care has kind of shifted quite a bit.
Mm-hmm.
But I've seen just in the couple weeks that I've been with this new practice that people really value that. And I've heard that even as I was trying to practice in the midst of another company.
Yeah.
People really value if you say that you take care of them and then you're actually doing it.
Mm-hmm.
And it may be spending just a little more time to understand it, or there's this thing in a lot of primary care clinics where you may go in and it's like, hey, I have a cough, but I also have this thing on my toe and I'm kind of concerned about my digestion. And they're like, hey, you got one thing, or you got one maybe minute left to spit out something about a second thing.
Yeah.
But you need to make another appointment. So that's another copay for you. It's another day off work for you. It's all these other things.
Yeah.
So people care about you saying, hey, I'm going to spend that time with you to really address what you want to be seen for, but that person is going to come back because they know that you actually care about that.
Sure. Mm-hmm.
And it can be a little more tiring in those appointments because you're really trying to address a lot in a short period of time.
Yeah.
But that patient base is going to keep coming back because they know that you actually care about it.
Sure. Yeah. Okay, so let's walk through a work week or a work day, and I'll give you this scenario to kind of help paint the picture of what it looks like. So let's say I've called up your office and like I need to come and see Steve because I've had a hacking cough for 4 days and it's hard for me to catch my breath after I cough. All right, I come in.
Go.
You call me back. Go.
Okay. Yep. So you're assigned an appointment time. You show up right about then. When you get there, I will have already looked at your chart, looked through your medications, maybe seen maybe this is causing a cough.
Where does that come from? Let's say I guess I've seen you one time already.
Okay.
That's just you've already logged all of that from my prior visit, or if I've changed doctor's offices, how do you get that information?
Yeah. Okay. Yeah. So as a new patient, you come in, and I'm experiencing this right now where I'm seeing some new people coming over. And so we would spend a little extra time at that appointment, and I'd ask you about your personal medical history, medications that you're taking, social history, like do you smoke? Is that what's causing your cough?
Yeah.
Do you drink? Things like that. And then your family medical history, because that can sometimes clue us into some things. Do you see any other specialists? What surgeries have you had in the past that could be contributing, or it's just good to have in your chart type of thing? And then we would transition to what we call HPI, the history of the present illness. So that's what really goes in that subjective spot is tell me all about it. So when did it start? Is it producing any mucus? Have you been around anyone who's been sick? What medications are you taking at home to help this cough? Or have you taken any medications? Most people don't. They're like, no, that's why I'm here.
That's why I'm here. I need you to tell me to go home and
NyQuil's over the counter.
Take some NyQuil. Yeah.
But that's it. We're gathering information. So there's this discovery phase where we're saying like, tell me about it, basically.
Yeah. I like that.
Proprietary, yeah. So
yeah, your bill is in the mail.
That's copyrighted.
You can't say that.
So that's the discovery phase, and then we're assessing. So then I'm gonna have you hop up on the table. We're gonna listen to you, and that's where, in my mind, I'm starting to process through. Okay, here's what's been going on. Here's what I'm hearing and what I'm assessing. What do I think it is? What's that most common and what's the worst thing?
Yeah. Okay.
So in a young person, most of the time, that's going to be you have a virus and we just need to deal with it. If it's been going on for a while, it's okay. Maybe this has become bacterial. Maybe it is pneumonia. So we're trying to process through like the most common and then the worst things.
Okay.
Then we would go to like testing is a lot of what we do. So do we need to get labs? We live in Southwest Arizona or Southern Arizona, in middle of Arizona, wherever we are,
American
in the Southwest.
Yeah.
We're in the Sonoran Desert. So there's something called valley fever out here that we don't see in other parts of the world.
I'm definitely afraid of.
There you go. It's terrifying. So I have to think through, okay, is that part of my, what we call a differential diagnosis? Okay. So that means I don't know what's going on, but these are the things that I think it could be. That's what a differential diagnosis is.
Okay.
And so I would say viral, upper respiratory infection, pneumonia, valley fever. Might be my top three.
Yeah.
And so to rule out pneumonia, I can listen and I can say, okay, I hear some crackling in the base of your lungs, so I'm going to guess pneumonia. So we're going to treat you for pneumonia with, say, an antibiotic. But to confirm it, or let's say you're not getting better after 3 to 5 days on that, then we're going to go ahead and send you a chest x-ray and say, okay, go get that.
Okay.
To rule out valley fever, sometimes we see it on a chest x-ray, usually not. So you have to do blood work is really the confirmatory test. And so then I have that in my differential. So a lot of times this might be the split of how I deal with patients versus how like a big corporation would want me to.
Yeah.
If I'm saying I want as many appointments out of you as possible and we can say, hey, we're caring for you well, we'd say, I'm going to see you today. Here's the antibiotics. In 5 days, I'm scheduling a follow-up with you.
Okay.
If you're not getting better, then I'm going to order a chest x-ray. Then I'm going to order some
another follow-up.
But I got another copay out of you, got another appointment that I can bill. So we're building our practice, but really I'm creating appointments.
I see that, yeah. And the patient doesn't know any better. They're just like, oh, yeah.
Because you are taking good care of them.
Yeah,
I'm checking you out.
Yeah, sure.
I generally try, partly because I work in this part-time.
Okay.
And so I don't have unlimited appointment slots. And partly because I don't want to just do an appointment, just say, hey, you feeling better? Great. All right. See you later.
Yeah.
Leave your copay on the way out.
Yep.
I will order the chest x-ray. I'll
Okay.
order the lab work. And then I'll say, these are things that we're going to do in 5 days if you are not feeling better with this antibiotic. I'm going to treat you with the antibiotic.
Yeah.
We have a text system that goes right to our Google phone. So like I see it every time someone texts in. And so does my medical assistant. So her responsibility is to respond to those, but I can see them as well. So if I see something, I'm like, okay, I know that patient isn't doing better.
Yeah.
So they may text back in and say, hey, I did that chest x-ray.
Yeah.
But I try to put a little responsibility on the patient to say, you need to let me know if you're not better in 3 to 5 days. I put that in my note. So that's kind of that liability that we were talking about. Like I covered myself.
I have said that they need to let me know.
Yep. And I'm ordering this. And I'll put in my note, he is not going to do this unless he's not feeling better in 3 to 5 days.
Okay.
Same with blood work.
Okay.
So then if I see those come back, I know in my mind that patient's not feeling better. And then I can look at the testing and say, okay, yeah, this is just something that's hanging on. Maybe we need to switch your antibiotic. Maybe we need a little different treatment. Or, oh, you actually do have valley fever, so we need to get you started on a different treatment. And that'll prompt me to then call the patient and say, hey, I got your results. This is what we're seeing. You actually have valley fever. The treatment for pneumonia is not going to hurt you. A lot of times it makes you feel better, but you're not actually better. You have valley fever, so we need to start this antifungal.
Okay.
And so that's kind of if you were a new patient with a cough, that's kind of how we'd work through it.
Okay.
And then we'd eventually schedule a follow-up. So especially for young people, it's, hey, as long as you're feeling better, I don't need to see you again for 6 more months. And then we'll talk through some of your ongoing stuff at that point. So yeah. that's how
Cool.
it works.
And is your medical assistant at like your prior one where you work so closely together, does she take a lot of that communication from you because you have a much larger patient load, right? So
Yeah.
she would kind of take over that. You would say like, oh, they need to order this, make sure that they follow up with it
Yeah.
or whatever.
So the communication on follow up and what we're going to order,
Mm-hmm.
that's me with the patient. But
Okay.
usually, some providers, especially if you're not real busy,
Mm-hmm.
you could like go talk to them, come out, think about it, Google some stuff, look at our references, and be like, okay, I think I'll do this, and then go back in and be like, all right, we'll do this.
Yeah.
I try to go in, we're formulating the plan. I'm telling you, hey, these are the things we're going to do. Let's say we're going to do a flu test.
Mm-hmm.
It's like, hey, we're going to swab you. It'll be back in 10 minutes. If it's positive, I'm sending in this. If it's negative, this is what I think, and we're going to do that.
Nice.
And so then my medical assistant will swab. She'll go back and say, hey, it's negative, so he's going to send in what he said he was going to send in.
Okay, gotcha.
But then after they leave, especially at the bigger practice, there was no, like, I wasn't seeing the text back and forth. That was going to the front desk, and then the front desk would get it to my medical assistant. Medical assistant would get it to me, and then I'm going back to my medical assistant, and she's calling. If they don't pick up, goes back to the front desk. So we saw a lot of poor communication, and patients were very frustrated with that because they know how I operate, where I'm like, hey, let us know.
Yeah.
And then they call the front desk and they're like, oh, great, we'll schedule you an appointment. And they're like, well, no, Steven said to
Steve
let
said
me
let him
know.
know.
He gave me the chest x-ray order already. Okay, so you want an appointment? No. Just get this message to Steve, and then we've already dealt with it.
Yeah.
Whereas now it's a very direct communication line. So the medical assistant still deals with it, but because I can see it, I can see one pop up, and I'm like, yeah, he just needs to do that chest x-ray that we gave him 2 days ago.
Yeah.
So just have him go do that. I'll watch for the result, and then we'll go from there.
Gotcha.
So we do try to keep that as streamlined as possible, but the medical assistant is your main flow for that communication. Yeah.
Gotcha. All right, so talk me through. Let's start with a nightmare day or week. You can do whatever. If you have examples, that'd be awesome. But
yeah, for sure.
Generally, what's a nightmare day look like for an NP?
Yeah. I haven't had one yet. The new practice, which is nice. So that's been good. Hopefully I don't, but I'm sure they'll come eventually. At the old practice, what it would be. So there I was working 10-hour days, and I had 25 patient slots that were open, or probably 27.
Okay.
So nightmare day would be I walk in and there's a 27 at the top. So I know that there's a ton of people in there.
Yep.
Which is generally fine if you're running like an urgent care where it's coughs and it's splinters in your finger and stuff like that. You can deal with that. The type of patients I deal with are primarily Medicare. So that's a big split in the medical world too. Like, do you see a lot of commercial patients, so non-Medicare patients, which are usually younger, generally less complex. Stuff's going to get covered a lot easier, whereas with Medicare, higher complexity, they're all going to be mostly over 65. A lot more meds that you're trying to manage, a lot more denials of medications that you're then trying to find alternatives because the insurance company isn't covering what we want to prescribe.
Yeah.
So I see a lot of Medicare patients. So if I see a 27 and then I can look down and I see insulin pump, type 2 diabetic, this person talks for 40 minutes every time I see them, and I'm like, I only have 15 minutes with all these people, that's going to stress me out to the max because then you have to shift your whole focus in that appointment, and there's an internal clock the whole time. And I have to figure out what's going on, assess the patient, address what we're going to do, say my pleasantries, and get out. And not let them know that I'm like, I can't talk to you right now. I need to go and see the next patient. And I care about you, but I also have 26 other people who I need to care about. So that would be nightmare day, where it's just an overload where I don't feel like I can address the patient's needs in that time slot, or they have no concept that they're not the only patient that I see.
Yeah. Okay. So then what's a perfect day? What's like everything was a success? What's it look like?
So the number may not
5
be
patients.
as big of a deal. Right. I spend an hour with each patient. Especially now, it's a little more like that. So I like yesterday I had 10 slots and I saw 8 patients. It was a great flow. People came in, they really had one thing they wanted to address. They're like, hey, I need some refills. My diabetes is going great. They brought their lab slip in that they had brought from our previous clinic. And we just kind of got to talk through that, address some of their needs, and move on from there. So that's a nice one when patients are not upset with you, when all the meds go through and insurance doesn't throw a fit. And then when there's really nothing that stumps you is a nice day.
Okay.
I
Yeah.
like to go home being like, hey, I did well
How
today.
often do you get that encounter where it's like, I don't know what's wrong with you?
Quite a bit,
Really?
honestly. Yeah, that comes up a lot. Especially, I think when people come in with those new acute problems, maybe it's a
Mhm.
patient I see all the time for their chronic care
Mhm.
management, but they come in and right at the end they're just like, oh, also I've had this.
Mm.
And I had one of those not too long ago where it was someone that I heard their complaint and I said, we call it complaint. We're not meaning like complaining, but that's what we just term it.
Yeah.
I heard their concern. And I thought, yeah, it's probably a strained muscle. So we treated it, didn't get better, came back, ended up being this like large mass on their kidney, which I ordered an ultrasound just to be like, hey, let's check your kidneys
Just
out.
rule that out.
There it is.
Wow.
So we do get that quite a bit where it's like, I would not have gone there with the symptoms he was having, but it was a more, I have no idea. Let's go ahead and get some basic imaging.
Yeah.
And that's what it was. And
Wow.
so we get that a fair amount. And I found there's this line of being honest with the patient and also not looking like a dummy
Yeah.
because they're coming to you
Sure.
for your expertise.
Yeah.
And so that line can be hard to toe, but you always have to remember the other resources you have. So we have specialists, we have testing, and just being upfront with the patient on like, here's what I think it probably is. We run into that sometimes with these, like, what is the worst possible thing? So acute hearing loss is a big one that we have to weigh that.
Mm-hmm.
So I had someone coming in not too long ago who they did have some acute hearing loss, and I had just talked with my dad about it, who's an ENT, and he's like, that has to go to ENT right away because they can permanently lose hearing if you don't address it.
Yeah.
Hers was a little like, I don't know about this presentation, but I told her up front, I'm like, I don't know what is causing this for you.
Yeah.
Here's a treatment that I think we would use for the common thing, which would be like, sinus congestion. We call it eustachian tube dysfunction, where there's just fluid backed up in your ear.
Mm-hmm.
This is going to treat that, but I also think that we could be dealing with a cochlear issue where you are not hearing, and that may not come back if we don't get you treated right now.
Yeah. Okay.
So here's what we're going to do to cover both of those.
Yeah.
And the upfrontness with the patient, I think sometimes it can scare people a little bit when you're like, hey, you could permanently lose your hearing. But sometimes putting that little bit of urgency in there, like, I'm going to call and get you an appointment tomorrow with an ENT. So you have that.
Yeah.
But I think it's this, which is very common and treatable, and you'll be fine in 3 days.
Yeah.
So sometimes being just open and saying, here are some avenues that we can go down. We have a plan to figure out what's going on. I think a lot of people want to know that you have a plan.
Mm-hmm.
Even if you can't give them a diagnosis that day,
Sure.
knowing that you have a plan of what we can do is comforting, and it's responsible because we're trying things.
Mm-hmm.
When you come into a doctor's office with a question, concern, and then it's kind of just this punt of like, yeah, I got no idea. Go talk to someone else, or I'm going to send you to pulmonology because maybe they have a thought. People leave like, well, what the heck? That guy doesn't know, and he doesn't even know where we're going.
He's supposed to go spend money at these other specialists.
Yeah, go see this person who can't get you in for 3 months anyway. But sometime we'll figure it out.
Yeah,
and that's where a lot of those people probably end up in the ER, which is also poor patient care, and it's poor patient care just to expect that person to figure it out on their own.
Yeah.
And then it's poor resource management because now they're spending some people's copay for the ER is like $300, and then you're going to get a bill on top of that. So we're really strapping the patient, unfortunately.
Yeah. Rough. Okay. What's something in your world? So I like to say, like, take us into your world. What's something that you see or experience or observe consistently that most people don't consider or don't realize?
Yeah. Probably the most common thing that I would think about would be the billing side of healthcare.
Okay.
People see a bill when it comes out, but they really just see you in the office. So I think the thought is like, hey, you just see people, and then I get a bill in the mail.
Yeah.
And you kind of miss the behind the scenes part or the chart.
Mm-hmm.
Sometimes I'll talk to patients about that, and it's very interesting for people to hear, but you still don't really grasp the behind the scenes part.
Mm-hmm.
And so when I'm sitting there with you, I'll have my laptop out, or I'm typing on the computer sitting behind me with a wireless keyboard, but I'm trying to put everything in that you are saying so I don't miss stuff.
Gotcha.
And then after you leave the room, then it's like, okay, I need to go back. We use dictation software, so I'm dictating the stuff that I didn't get to type out,
Mm-hmm.
because I try not to have it where I'm like just sitting there in silence typing while the patient's just like, so
Right.
what's up?
What do I
Hang
do
on.
now?
I got to type this in. So then I'll try to dictate real quick
Okay.
the rest of it, and then I've got to change the ROS and I got to change the assessment to
Yeah.
match what we did.
Yeah.
And then the plan, I'm trying to be like, okay, I know I want to do this, so I'm spitting that in real fast before the next patient gets brought into the room.
Yeah.
And so I think people miss that side where it's like, I got to make the chart match up with what we talked about to help you with the insurance side of it, to make sure you have continuity of care the next time you come in,
Mm-hmm.
so that we can reference that. And then the fee side of it, I'm trying to make sure like you can bill stuff really quick if you did very poor billing, or
Mm-hmm.
insurance would love it because they don't have to pay you much.
Yeah, sure.
But you wouldn't love it when you
Mhm.
start to see your check.
Yeah.
So you're having to accurately represent what you did with the correct codes so that it's
Yeah.
going to get billed properly. So
Yeah.
I think people just don't think about that side, the behind the scenes part.
Mm-hmm.
When you think about, oh, I got 30 minutes with a patient, it's like, oh, piece of cake. I can chat with someone for 30 minutes and figure everything out. But if you spend that whole 30 minutes just chatting, then you haven't addressed anything medical and you haven't done any of your charting. So you're really looking at like 20 minutes, maybe 5 on the front end where you're trying to prep it,
Mm-hmm.
5 on the back end where you're trying to wrap it up. And then you got that 20-minute spot to really like figure out what's going on and assess them. So that's probably what people don't see or don't
Yeah.
think about.
Yeah. Cool. What? 2 more questions. One of them real quick. Let's say I go to the doctor, or bring my son to the doctor. We med tech weighs us, blood pressure, whatever. Doctor will be right in to see you, and then it feels like a calendar day before
Yeah,
the doctor actually
sure.
walks in.
For sure.
What are y'all doing in that time?
Just chilling at
Give us an
Starbucks.
answer.
Yeah. So there's probably the correct medical answer is we're with another patient generally,
Oh.
or we are doing that chart prep.
Okay.
And some of those nightmare days that you look at,
Mm-hmm.
that's when you're like 30 to 50 to an hour behind,
Yeah.
because maybe it's just one patient that was kind of off the rails and you had to deal with a medical problem that was really severe. Like we're sending someone to the ER, so everything pauses.
Mm.
You're just locked into that patient, and then
Yeah.
you're playing catch up the rest of the day.
Yeah.
Sometimes it is just, hey, I'm prepping your chart. I want to
Mhm.
look at something first. I want to look up a lab. So when I walk in the room, I have an idea of what's going on already.
Yeah.
Or, you're an ER follow-up. So I'm looking at your ER record to see what did they do? What did they find? And then what do we need to do from here?
Yeah.
The other side of it is drug reps. When I'm behind sometimes,
Okay.
honestly, that's it. My last practice, we would have at least one drug rep every day that I was there.
Wow.
I was one of the only ones who would talk to them because you can learn a lot. It's biased information, so you have to keep that in your mind. Like
Sure.
they're trying to sell you a product, but at the same time, they're only allowed to say things that are proven by their science, and
Okay.
so you can learn a lot from the drug reps.
Yeah.
And so they would always show up at 9:00. Well, I have a patient scheduled at 9:00, so I'm trying to run in between the 8:45 and the 9. Talk to them real quick. Grab my Starbucks from them and chat it up and see why I should prescribe their medication.
Yeah.
But they're also a good resource. So sometimes if you've had an insurance issue, like, hey, I prescribed it and they didn't cover it and you said they would,
Yeah.
what's the deal?
What's the deal? Yeah.
So they can help with some of those insurance issues too. So that would be the other side. That's a common one.
Mm-hmm.
We don't really have drug reps at the clinic I'm at now, but
Mm.
at a lot of clinics, that's sometimes why you're waiting.
Yeah. Interesting. Okay.
Yep,
Cool.
yep.
Well, thank you. I think that's everybody wants to know.
Honest answer.
That's
Yeah.
honest answer.
Right.
All right. Then last question. This is our bonus question that comes at the end. I try to keep it broad, but I like to ask, what gets you out of bed in the morning?
Yeah. I really enjoy taking care of diabetic patients. So that's one thing that I have had a desire to do since I was in high school. I got diagnosed with type 1 diabetes when I was 16. And that is kind of what drove me to the more direct patient care side of things. I initially wanted to go into more like biomedical engineering, developing medical stuff. I didn't think I really wanted to be a direct patient care person. And that shifted it because I saw the care that I received and I was like, this is really cool. And I think I'd enjoy taking care of people with this problem.
Yeah.
So that's what I do like doing it. It does pay the bills too. Like that's a part of it. But I've always liked that idea of being able to care for people and use the knowledge that I have to make a positive difference for them. So that's what gets me out to the clinic. And then we also use this for missions. And so when we go overseas, the knowledge and the experience that I'm getting here
Mm-hmm.
helps me take care of patients in Costa Rica and other places that we go to, and we use that to bring the gospel to them and help grow the churches there. So that's what's always driven me. And the medical side in general is
Mm-hmm.
like, hey, pushing us towards missional work.
Awesome.
But yeah, that'll be it.
Very
Yep.
good. Awesome. Well, Steve Panosian, nurse practitioner, thank you for coming on and telling me
Yeah,
about it.
thank you. Appreciate it.
All right.